assuming that C-spine, like case closed, this is over, we're not worried about radiation, we have these good decision rules, we're all CT imaging those. What are we doing in the thoracic and lumbar spine? Because we don't have a decision rule to help us determine who is higher risk, who needs imaging versus who doesn't.
That's the real problem here, is the threshold to image a patient. Often when I'm imaging the TRL spine, I think the pretest probability is exceptionally low. So boys, what in your mind, other than obvious stuff, step-offs, deformities, paresthesias, in a patient that's well-appearing walks in, what makes you decide to image the TRL spine? And alternatively, what makes you not image it?
So for me, it really comes down to exam and it's midline tenderness. So if the pain is outside of the midline, I assume it's musculoskeletal, or it's something that's peripheral that a CAT scan or an X-ray is not going to help me with. And then it's the other risk factors they might say that they have, whether it's a cancer patient or somebody that has a history of previous compression fractures, that maybe raises my thought to, well, you're having pain, maybe I'll get an image. But those are really the two that come to mind.
Yeah, it's the traumatic red flag back pain symptoms right now. I can't say it's the true back pain red flags that we consider when we're worried about epidural abscess or something along those lines, but in the trauma situation. Andy, I would add a modifier to the midline back pain, which was, I would say, significant midline back pain. Now, I say that, and I just walked into, quicksand, because that is a very nebulous concept. What is significant midline back pain? And to me, might be different than to any of our other listeners. But I am not just jumping reflexively to get any type of imaging on a patient that has mild midline back pain. Like, oh yeah, it's a little tender, but they're absolutely fine otherwise.
Also, I think the incidence in a walking wounded patient of finding a clinically significant injury in the TRL spine is actually pretty low. Can we find compression fractures? Yep. Can we find in-plate fractures? Yep. And what happens? They sit around forever. They may get a TLSO brace, which they hate, which doesn't have a lot of evidence to support its efficacy. And so a lot of this, I think, is kind of knowing when, or getting a sense of when to turn a blind eye, because a lot of these injuries, I would argue, patients don't really need to know about, because they don't pose risk to the patient other than you're going to hurt for a little while and you will get better.
Yeah. And Delaney, I think that is where this all hinges on. If they don't need to know, don't image them. But if they do need to know, get the imaging modality that is going to actually give you the information. So similar to cervical spine X-rays versus CT, the numbers are staggering as far as sensitivity and specificity compared to those imaging. So CT scans are in the high 90s in multiple studies for clinically unstable and significant fractures and injuries, where the numbers for plain film X-ray images are between 30 and 60% specificity and sensitivity. And that's just bad.